I'll be presenting the first article today. So it's an article that was produced by the American Society for Reproductive Medicine on the efficacy and safety of the combination of Estetrol, 15 milligrams, and Drospirenone, 3 milligrams, in a cyclic regimen for the treatment of endometriosis-associated pain and objective gynecological findings. It was a multi-center, placebo-controlled, double-blind, randomized study, and the authors were Tasuku and al. So endometriosis is a chronic inflammatory condition affecting women of reproductive age that worsens their quality of life because of various chronic menstrual, low abdominal pain and back pain, defecation pain, and defecation pain. So in terms of current therapy, guidelines recommend combination estrogen and progesterone drugs as the first-line therapy, with ethinyl estradiol being the most commonly used estrogen in combined oral contraceptives. And this affects the vascular endothelium and liver protein synthesis related to hemostasis and blood pressure, increasing the risk of cardiovascular complications. Estetrol, which I'll refer to from now on as E4, is a native estrogen with selective tissue activity and a potentially safer profile. So I will just look at the differences between estradiol and estetrol. So estradiol activates both nuclear and membrane estrogen receptors equally, resulting in a wide range of effects on the uterus, bone, and stimulation of liver proteins that increase clotting risk. In contrast, estetrol is a synthetic analog of a natural estrogen that is synthesized by the fetal liver and present only during pregnancy. It is not metabolized to estradiol or estriol. So it acts mainly through nuclear estrogen receptor alpha while blocking some membrane pathways. So this selective tissue action may translate into a lower risk of venous thromboembolism compared to traditional estrogens. So in phase 3 studies outside of Japan, E4 and Drospirenone met the oral contraceptive criteria, receiving global regulatory approval in 2021. It achieved sufficient ovulation suppression with a low frequency of unscheduled bleeding and minimal effects on lipid and glucose metabolism and hemostasis. It also has a lower estrogenic activity and possibly with decreased thromboembolic risk. So this study aimed to confirm the clinical efficacy and safety of this drug in patients with endometriosis. So the objective of the study was to confirm the superiority of E4 Drospirenone combination over placebo in the treatment of endometriosis-associated pelvic pain after 6 cycles of treatment with 24 days followed by a 4-day hormone-free interval per cycle. The study was conducted from the 2nd of August, 2021 to November 2022. It was a multi-center study conducted across 25 centers, randomized, double-blind, placebo-controlled. The duration was 24 weeks, and the population were 162 Japanese women with endometriosis with a visual analog score of more than 40 millimeters, which we'll discuss later. And the intervention was to give one group the E4 Drospirenone cyclical regimen versus placebo. So the inclusion criteria was women who were more than 20 years who were diagnosed with endometriosis. The clinical diagnosis was determined by laparotomy, laparoscopy, transvaginal ultrasound, MRI for the existence of ovarian endometriomas, or gynecological examination. Endometriosis-associated pelvic pain score of more than 40, they had to have an endometriosis-associated pelvic pain score of more than 40 millimeters on the visual analog scale during the baseline observation period, had to have regular menstrual cycles for the last 2 menstruations before randomization with the BMI of less than 30. They had quite an extensive exclusion criteria. For gynae, they excluded women who were undiagnosed, who had undiagnosed abnormal uterine bleeding, those who were more than 40 years of age with large or solid ovarian endometriomas that were more than 10 centimeters in size, or which had solid components, patients who had recent surgery for endometriosis, adenomyosis, or fibroids, who had no response to prior hormonal therapy, or who had indications for surgery. In terms of medication-related exclusion criteria, they excluded women who had regular analgesic use for non-endometriosis-related conditions, who had recent hormonal therapy, who were taking drugs that affected combined oral contraceptives. In terms of medical history, they excluded women who had a history of venous thrombotic events, stroke, coronary disease, migraine with aura, severe liver or kidney disease, diabetes with vascular lesions, or thrombogenic mutations. Women who were pregnant and lactating were also excluded, and those who had severe depression, hypersensitivity to the drugs, who had planned surgery or bed rest, or were unwilling to use barrier contraception. In terms of the treatment, the eligible participants were randomly allocated to either the E4 drospirenone or placebo group at an equivalent ratio balanced by the visual analog score of less than or 60 millimeters and comorbidities such as uterine fibroids and adenomyosis after more than 2 menstrual cycles. Immediately after randomization, the participants took 1 tablet daily from the first day of menstruation. Participants in the treatment group were treated with a cyclical regimen for 6 consecutive cycles. The placebo group received oral placebo tablets daily for 28 days over 6 cycles. Rescue medications such as loxaprofen and ibuprofen were allowed as needed throughout the study. Randomization codes were created using a computer system with a block design and managed by an independent office to ensure that neither the researchers or the participants knew which regimen was being given. So they used 2 validated pain scales. The first one is the visual analog scale. It's a tool basically to measure the intensity of pain or symptoms on a continuum, usually represented by this 10 centimeter or 100 millimeter line. So with 0 being no pain and 10 being the worst imaginable pain. They also use the numerical rating scale, which is a pain assessment tool as well. So here the patient is asked to make 3 pain ratings corresponding to the current best and worst pain experience over 24 hours, and then the average of the 3 ratings is taken as the patient's level of pain over 24 hours. So during the baseline observations, the treatment periods, the participants were required to grade their most severe endometriosis-associated pain with the visual analog scale, which was installed as an electronic diary in their devices, which they did this daily. And the baseline was the most severe pain during the pre-randomization observation period. In terms of primary outcomes, the primary outcome was the change in the visual analog scale score from a baseline for the most severe endometriosis-associated pain, which included menstrual and non-menstrual pelvic pain, dyspareunia after 6 cycles. Then in terms of the secondary variables, they were also collected using these electronic diaries by the investigators. And for the clinical part, the examination was done at baseline and then again at 24. Physical examination was done at baseline and then again at 24 weeks. So in the secondary outcomes, they looked at the numerical scale score for pelvic chronic acute defecation and pain and dyspareunia. And they looked at responder rates achieving a more than 30% or more than 50% reduction in the scores from baseline to the 6th cycle. They looked at gynecological findings such as cul-de-sac induration, pelvic tenderness, and uterine mobility. They looked at endometrioma, a change in endometrioma size and quality of life improvements, and lastly, if there were any treatment emergent adverse effects. So the study included 162 participants. that were from 25 clinical sites in Japan. So for the E4 the placebo, after the full analysis set, 4 in the drospirenone E4 group, there was 4 subjects withdrew, which left them with a number of 75, and in the placebo, 3 subjects withdrew. There was 1 adverse event, which was a raised D dimer in one of the patients. So that patient was excluded. And there was an investigator's decision. So there were 2 participants that were excluded because the investigators thought there was a breach of the study protocol, and it ended up with a 77 in the placebo group. So in terms of results, demographic characteristics were comparable between the groups. The mean age and BMI were 34.7 years and 21.4 kilograms per meter squared, respectively. Of the 162 patients, 27% and 16% had concomitant adenomyosis and uterine fibroids, respectively, and both comorbidities were observed in 13 patients, which accounted for 8% of the group, and the groups showed negligible differences. So this table shows us the pain reduction by means of the change in the visual analog scale for the most severe endometriosis associated pelvic floor was decreased by a mean of 33.2 millimeters from baseline after 6 treatment cycles with E4 and drospirenone, and in the placebo group, it was decreased by 22.2 millimeters, 8.5, with the confidence interval with a 95% confidence interval of 16.1, value of 0.02, which is significant. We have 2 graphs here. The first graph shows us the responder rate with the visual analog scale. That's an NRS scale. So in the first, in A, the responder 30% was percent, and 36.4% in the E4 drospirenone group, respectively, and it was significantly different from the placebo group, with the between group difference of 23 for the addiction and 24% for the 50% reduction. Note that the E4 drospirenone group significantly relieved pain in the so the dark blue difference, sorry, and the between group difference rates were 18.8% for the 30% reduction and 24% for the 50% reduction. And then in terms of clinical improvement, while E4 and drospirenone significantly improved the general pain intensity, it actually did not show any significant benefits for dyspareunia and defecation pain, with the p-values being 0.7 and 0.06. So after 6 treatment cycles, in the treatment group showed objective improvement in gynecological findings. For the pelvic signs, 23% showed significant improvement in the cul-de-sac in duration and uterine mobility with no worsening. In terms of pelvic tenderness, progression was prevented in 1.3 versus where there was 1.3 versus 12% in the placebo group. And then in terms of the ovarian endometriomas, the volume of the largest endometrioma was reduced by 44.5%, with 7.7% actually disappearing completely. The serum CA-125 returned to normal in 19.2% versus 2.4% in the placebo group. Other benefits were sleep disturbance, which improved significantly, with 52.6 reporting that they were not disturbed at all. The global impression improved by 45%, and the rescue medication use was slightly lower in the treatment group with 1.71 versus 2.85 days, but this was not statistically significant. In terms of adverse events, 97.5% occurred in the treatment group versus 86.7% in the placebo group. In the treatment group, there was intermenstrual bleeding, which was common initially, with 51% of them having it in the first cycle, but it dropped to 24.4% after treatment. Spotting became the main bleeding event after cycle 3, accounting for approximately 50% of the bleeding events. Intermenstrual bleeding or spotting occurred after the second treatment cycle, and it usually lasted less than 1 day after 2 cycles. The treatment emergent adverse effects in the treatment group were actually similar to other oral contraceptives, which were nausea, headache, upper abdominal pain, diarrhea. There were no serious events noted. The one patient that was discontinued in the placebo group had a high D-dimer, and there were no deaths and no clinically significant lab changes or hemostasis issues. So for the discussion, endometriosis severely affects quality of life, mental health, relationships, and work productivity. So delays in diagnosis and treatment worsen this impact, which highlights the need for early detection and effective long-term management. Surgical management often has a high recurrence rates and can harm ovarian function. Hormonal therapies help to control pain and lesion progression, but require continuous use to remain effective. Traditional oral contraceptives, which contain high estrogen doses, may increase the risk of deep infiltrating endometriosis and VTE. So why do we want to use E4? It's because it has lower estrogenic activity and less impact on blood clotting compared to ethinyl estradiol, making it a safer option for a long-term use. So the key study findings were that E4 and drospirenone significantly reduced the most severe endometriosis-associated pain, with approximately 40% of participants achieving a 50% pain reduction and 50% achieving pain scores below 40 millimeters. Gynecological exams showed reduced pelvic tenderness, improved uterine mobility, and a notable 44.5% reduction in endometrioma size. Quality of life measures and global impression scores also improved markedly. In terms of safety, intermenstrual bleeding was the most common side effect, but declined with ongoing treatment. There were no VTE events that occurred, and safety was comparable to placebo in terms of blood clotting markers. The limitations of the study was that it did not assess recurrence or fertility outcomes after stopping treatment, but there is an open label 28-week extension that is going on to evaluate the long-term safety and efficacy of this drug. So in conclusion, the study demonstrated that E4 drospirenone is clinically effective for endometriosis-associated pain treatment with improved objective gynecological findings, quality of life, and global impressions in patients with endometriosis. Estetrol and drospirenone should be considered a first-line treatment for endometriosis treatment. So in terms of the unit comments, we thought that the strong points of the study was the study design. It was randomized control trial, placebo-controlled, double-blind, which makes it of high quality because there's minimum bias. So it makes us, it reassures us that the results are more reliable. There was a safety profile of the drug. It showed no serious or adverse events for venothrombotic events, which is the main thing that we're looking at. It used objective clinical endpoints and validated pain scores to give more accurate results. They even used the same examiners to examine the patients before treatment and at 6 weeks after treatment. In terms of areas for improvement, there was an extensive exclusion criteria, which might limit the generalizability of the results. Rescue medication use was actually similar in both groups, which actually asks us if there's an actual clinical impact if the use of analgesia was the same between the groups or was slightly different, which was not significant. The endometriomas that were measured in the study were actually quite small. In the supplemental tables, they said they were around 25 to 26 millimeters by 19 to 20 millimeters. So it might not really represent a meaningful clinical benefit because the baseline size of the cysts were small to begin with. There was no mention of endometriosis stage, so we don't know if these results are applicable to both mild or severe forms of endometriosis. Only patients who had a normal BMI were included, and they actually excluded patients with high BMI, which are the ones that have the highest one of the highest VTE risks. And the treatment didn't have any impact on dyspareunia and defecation pain, which is usually a sign of deep infiltrating endometriosis. So it might give the impression that the medication really works for general pelvic pain rather than for endometriosis. So in terms of application to our setting, because of our limited resources, having an effective long-term treatment with a safer side effect profile would actually be of benefit to us if more studies are done and the safety and efficacy is actually proven. Thank you.
Thanks, Dr. Nkuna, for that presentation. Yes, so apart from those findings that we noted, there was also just a single ethnicity that was studied here. So it was just Japanese women, which can make it a bit difficult to generalize the findings. And if you read through the disclaimers at the end of the article, a lot of the investigators actually work for a pharmaceutical company called Fuji Pharma. And that company actually manufactures this drug, which is known as Nixtellus. That's the branding for it. So that could introduce some conflict of interest and some bias in the results. And we did recommend, as part of our conclusion, think that, head-to-head trials versus other COCs would also be of benefit. And even trials looking at E4 versus Dynogest, also known as Vizan, would also be interesting. And this study looked at a cyclic COC regimen. And for the conventional COCs, we use a continuous cycle. So looking at maybe this study in a continuous regimen versus the cyclic regimen may also be interesting. All right, do we have any questions, comments? We'll start with the floor. Anyone online?
Good morning. Can I make some comments?
Yes, Dr. Rampal?
Yeah, I think thanks for bringing out the first point in terms of disclosure, because obviously this is an industry-driven study. So once you get industry-driven, especially funding of a study, one can anticipate, you can get bias and the results people will question. Secondly, is that I was surprised that, in your introduction, and I know that it was mentioned in this article that combined oral contraceptive pills is still the first line treatment. I think if you look at the ESHRE guidelines, the World Endometriosis Society, the American Endometriosis Society, and in fact, most societies in the world would regard progestogens as your first line treatment, and that it has replaced combined oral contraceptive pills. I think the other points that you made were very valid in terms of them looking at the using pain scores, but at the same time, in their study, they had patients where they introduced anti-inflammatories, because obviously that would change the overall scores of these patients, because as you know, anti-inflammatories are used for modifying pain. The thing about endometriomas is a very valid comment again, because it is well established in the literature that continuous combined is far better than using cyclical for endometrioma suppression and recurrence. That is either using it initially in cysts less than 3 centimeters, or you are using it in after surgery for prevention of recurrence. So yes, they're showing again a cyclical type of pill showing a reduction, but that is still not as effective with other cyclical contraceptives as compared to continuous combined. I think also what is important is that we do understand that pain is a complete different, or the pain in terms of peritoneal endometriosis versus ovarian endometriosis versus deep infiltrating, right? There is no correlation with severity of disease. So it's fair to say, okay, they were looking at pain as the independent factor, because, I mean, whether it's deep infiltrating or whether it is ovarian endometriosis, the pains can differ. So at the end of the day, if they're looking at pain, then it's a reasonable study, but you can't correlate it in terms of disease suppression and recurrence. So I think that, as you mentioned, I looked at it, I mean, Dinogest, why didn't they use estrogen with Dinogest, not Dinogest, but with Dinogest as the progesterone component? It would have been a good if they had that combination, because as you know, when we look at endometriosis in younger patients, all right, we tend to try and prevent using Visan, but using the Clara, which contains estrogen and Dinogest. So if they use this together with Dinogest as their combination, I think it will show much more interest in endometriosis management as compared to using Drospirenone as a progesterone component. But otherwise, I think it's okay for a study just to introduce some new drug. Thank you.
All right, thank you, Dr. Rampal. Prof, your hand is up.
Yes, good morning. Thanks. Apologies, I'm late, very late. Yeah, I think I share the same sentiment, and I think for me the greatest shortcoming of the study is that it's placebo. Of course, it's RCT, but they could have used another agent. We all know that once you give endometriosis some form of progesterone. So yes, we appreciate the fact that there was a 40% reduction or overall improvement of symptoms, but you would expect that against the placebo. And the ethics of not treating someone who is already symptomatic and giving them placebo, I wonder how it got through. Whatever, as Dr. Rampal and you mentioned also, Dr. Suram, that it should have been compared against either a straightforward OCP or something that is like Vizen or something like that. So for me, that's the shortcoming really of the study. We expected the results. They are not surprising for me. Thanks.
Thanks, Prof. Okay, we're going to move on to our next article. So Dr. Kanana will take you through this study that was done in Israel that looked at pregnancy-related sepsis.
Compared to what it normally would be, and not just in Hawaii, but in other places as well. That's why we have these alerts in effect. Now, the orange part that you see here for the West
Good morning. As part of Unit 4, I'll present to you the second study that is coming from the Department of Obstetrics and Gynecology in Meir Medical Center in Israel that is attached to the Faculty of Medicine in Tel Aviv, Israel. So here they try to see the effectiveness of a cesarean delivery bundle with vaginal preparation, cefazolin, and azithromycin in reducing postoperative infection. This is a before and after study. Introduction. According to the WHO, cesarean delivery, you will see often CD here. Cesarean delivery rate worldwide is rising from around 7% in 1990 to 21% in 2023 and are expected to continue increasing over the current decade. Rates in USA are even higher, reported to be around 32%. Cesarean delivery is the most important risk factor for postpartum infection, resulting in significantly higher rate of postoperative infection compared with other surgical procedures. Common postpartum infection includes endometriosis, 2 to 7%, surgical site infection, 2 to 16%, and urinary tract infection, around 5%. A Cochrane review of 25 randomized control trial and more than 15,000 patients found the prophylactic antibiotic resulted in improving. Found that prophylactic antibiotics resulted in improvement in overall infectious morbidity. Surgical site and endometritis in both elective and intrapartum cesarean delivery. Antibiotic prophylaxis is currently recommended in all cesarean delivery and should be administered within 60 minutes before the skin incision. A single dose of first-generation cephalosporin, cefazolin, is the first-line antibiotic of choice and is recommended in all patients unless significant drug allergy are present. Over the years, several studies have reported conflicting results regarding the efficacy of an adjunctive macrolide infectious morbidity after cesarean delivery. A meta-analysis found that the benefit of adjunctive azithromycin was comparable to cefazolin alone. Assessing intrapartum cesarean delivery in particular, a multi-centered randomized controlled trial including 2,013 patients demonstrated that adjunctive azithromycin significantly reduced composite infectious morbidity compared with standard antibiotic regimen. The American College of Obstetricians and Gynecologists concluded that the addition of azithromycin to the standard prophylactic antibiotic regimen may be considered for women undergoing intrapartum cesarean delivery. However, antibiotic administration has a cost, given reported resistant pattern of isolated strains of E. coli in newborns after maternal antibiotic exposure. So, this study evaluated whether a bundle intervention for second-stage cesarean delivery, including adjunctive azithromycin administration and vaginal preparation with povidone iodine, reduced rates of post-operative infectious morbidity. So the objective is to evaluate the effectiveness of a cesarean delivery bundle, including preoperative vaginal preparation, cefazolin, and azithromycin administration that will be compared to cefazolin alone in reducing postoperative infection among women undergoing cesarean delivery during the second stage of labor. Material and methods. This before and after study included all women undergoing cesarean delivery during the second stage of labor in a single tertiary medical center from January the 1st, 2014 to January 1st, 2021. The study was approved by the Medical Center Ethics Committee in September 2021. The approval number is given. Due to the retrospective nature of data collection, individual informed consent was not required. In August 2016, the departmental protocol of that center for preventing infectious morbidity in second stage was changed from preoperative intravenous 2-gram cefazolin to preoperative intravenous 2-gram cefazolin, 500 azithromycin, and a vaginal cleansing with 10% povidone iodine on a sponge stick for 30 seconds before surgery. Medical records were reviewed comparing the first period from January 2014 to August 2016, and that's the control group, the cefazolin only group, compare with the period from November 2016 to January 2021. So if you check well, you'll note that the period from August to November in 2016 was excluded. This period was considered as protocol implementation phase. So from the participants were excluded those who had an elective Caesar, those undergoing intrapartum cesarean delivery but during first stage of labor, and those who, with intrapartum fever. That's 3. 4 patients allergic to penicillin were also excluded to avoid possible influence of other antibiotic regimen in the study outcome. Second stage of labor was defined as performed after women reached complete cervical dilatation. Indication including non-reassuring fetal heart rate, arrested in descent, failed operative vaginal extraction, and maternal compromise requiring immediate delivery, for instance, acute renal failure. Prophylactic antibiotics were administered. When it comes to obstetric characteristic post-operative infection and neonatal outcome were compared between the groups. Primary outcome measured was the composite infectious morbidity, defined as the occurrence of one or more of the following: endometritis, surgical site infection, intra-abdominal abscess, UTI. Of the post-operative infection, including the primary outcome, was also measured separately and compared between the groups. Endometritis and surgical site infection were diagnosed after clinical evaluation by a senior gynecologist with supportive laboratory and vaginal culture. Urine culture. Intra-abdominal abscess was diagnosed according to the clinical finding and ultrasound and/or CT scan. Data was retrieved from electronic database and, of the delivery room and cross-tabulated with data from neonatal unit. Data on maternal characteristic, delivery characteristic, infectious morbidities, and neonatal outcomes was retrieved. So, when it comes to the statistical analysis, categorical data were compared using chi-squared and Fisher-exact test, which, when appropriate, the distribution of each of the two when appropriate. The distribution of continuous variable was evaluated using Shapiro-Wilk test. Variable with a normal distribution were presented as mean standard facing standard deviation, and two groups comparison were performed using an unpaired two-sided t-test. Variable with an abnormal distribution were presented as median and interquartile range, and two-group comparison was performed using Mann-Whitney U-test. Multivariable logistic regression analysis was performed to reveal potential risk factors for infectious morbidity. Factors included in this analysis were independent variable that were significantly different between groups with p-value. With a p-value below 0.05. In univariate analysis, or variable thought to be associated with increased risk for infectious morbidity. Results were reported as adjusted odds rates, adjusted odds ratio, and 95% confidence interval. A p-value less than 0.05 was considered significant. All analyses were performed using SPSS 20. So, when it comes to the participants, in the center, there was a total delivery during that period from January 2014 to January 2021, total deliveries of 50,403. From those, intrapartum cesarean delivery were only 5,265, which is more or less 10% of the total number of delivery. The study cohort included 457, and that is because we consider only the cesarean deliveries that happened in second stage. So from that one, the Caesar bundle that we're looking at is 331, and the control group of 126 within that 457. Excluded vaginal deliveries, elective Caesars, twin pregnancy, gestational age below 24, chromosomal anomalies, and also excluded cesarean delivery during the first stage of labor, intrapartum fever, allergy to penicillin, as we said. Result. So in the result, they underline the maternal variables that listed here, like maternal age, gestational age above 37 weeks, nulliparity, smoking, etc. And then comparing the two groups, you will see that we have underlined for you here where the p-value is significant, like in nulliparity, in gestational hypertensive patients, in maternal anemia and maternal anemia at admission, where p-value is significant. All other maternal characteristics were similar between the two groups, like all that we saw on the list. And then when it comes to infectious morbidity, they looked at endometriosis, surgical site infection, intra-abdominal abscess, UTI, and fever of unknown origin after delivery above 38 degrees. When it comes to delivery characteristic, you have variable like P-prom, time from the rupture of membrane to delivery, group B streptococcus carrier, induction of labor, meconium, anesthesia, time giving, epidural, spinal type of anesthesia, etc., and second stage duration. For that, you look at your p-value comparing the two groups. You will see, for instance, in anesthesia, that in epidural, there is a p-value of 0.08. So you compare the two groups in view of the delivery characteristic. We'll give you the details about that a little in the conclusion. Infectious morbidity. Here, which is quite clear because this is what the study was focused on, you have composite infection outcome, endometritis, surgical site infection, all three following each other with a significant p-value, as you can see. Neonatal outcomes at similar rates in both groups, including APGAR score, pH, neonatal intensive care admission. So applying multivariable logistic regression, adjusted for maternal age, nulliparity, history of cesarean, gestational hypertensive disorder, etc., what we listed for you earlier, postpartum hemorrhage, etc., and neonatal birth weight, all that revealed that the Caesar delivery bundle intervention reduced the composite infection morbidity outcome with adjusted odd rates of 0.08, that is 95 confidence interval between 0.01 and 0.5, that's a p-value of 0.07. We'll bring up the discussion of. The present study demonstrated like lower rate endometritis, surgical site infection, and composite infection morbidity outcome with adjunctive azithromycin administration and vaginal cleansing for 30 seconds before second stage Caesar in the Caesar bundle intervention. Adjusting for confounder, the Caesar delivery bundle intervention significantly reduced the composite infectious morbidity outcome, showing a large effect size of 92% reduction with adjusted odds of 0.08. The possible efficacy of azithromycin might be related to its potential coverage against ureaplasma, urealyticum, and endogenous genital mycoplasma, thought to be present up to 90% in pregnant women. This study evaluated the benefit of an adjunctive azithromycin for reducing post-Caesar infection, specifically second stage, and found lower rates of endometritis, surgical site, and the composite infectious morbidity outcome in the bundle group. The beneficial effects remain after adjusting the possible confound. Notably, BMI was lower in the cohort, which was significantly lower than that reported in previous studies. Azithromycin exposure did not increase the risk for short-term neonatal outcome. However, long-term outcome will need to be evaluated, such as association between macrolide exposure and depletion of the gut microbiome, resulting in asthma and obesity in later in life. The present study is actually the first to demonstrate an efficient intervention for reducing infectious morbidity in the specific high-risk group of patients, high-risk group of patients, without compromising short-term neonatal outcome. Further research is warranted on a long-term neonatal outcome, as well as exploration of an optimal dosage and timing to maximize the efficacy and safety of the prophylactic approach. In conclusion, we say this was a single-center study which could reduce generalization to all population. The improvements demonstrated in outcome could have been related to the improved surgical technique or better infection and prevention control protocols. Vaginal cleansing is a possible confounder. Difficult to assess azithromycin efficacy alone. The median BMI was 24.2, which is significantly lower than that reported in previous studies and potentially reducing the risk of postoperative infection morbidity. And then additional research in population with higher BMI is needed to evaluate azithromycin's beneficial effect in reducing infectious morbidity after second stage Caesar. This study provides evidence that adding azithromycin and vaginal preparation to standard prophylaxis in second stage cesarean delivery significantly reduced postoperative infection, particularly endometritis and surgical site infection, without harming short-term neonatal outcome. However, we should interpret with caution given the retrospective design, small number, single-center design, and confounding intervention. Randomized controlled trials focus on second stage cesarean section should provide clear evidence in the future. Thanks. These are references.
Thank you, Patrick. So, yes, South Africa, sepsis is obviously a big cause of morbidity and mortality. So this is important for us. And our standard treatment guidelines actually do recommend adding azithromycin to cesarean section prophylaxis. But identifying or looking for the high-risk groups would actually lead to maybe more cost-effective interventions and reduce resistance. And as this article does mention, there can be some effect on the microbiome of the neonate. So yeah, I think it is important to look at who would be benefiting maximally from these interventions. Okay, we'll take comments and questions. Dr. Zita.
Thank you for the article. I've got one or two comments about it. Firstly, I was interested in terms of the 2 years with the capsule alone sort of thing, and then they had a transition period, and then about 5 years or so with the bundle. And I was just interested in terms of why wasn't it exactly like in terms of compared apples with apples in terms of the time. And then the second issue is during that transition period, could there have been not other things that they improved, like the antiseptic policies, scrubbing, and all of those issues, which could have influenced the results.
Okay, I'll answer the first part. Dr. Sir will comment the second. Actually, if you follow the way they relate their story, is that there was that change in protocol was an event that happened. Like they were applying the cefazolin alone all this time. And then in 2016, at that point, the protocol changed. The protocol change was not linked to the study. The idea of the study came to them after they have noticed that, okay, we have two populations here, those that were on cefazolin alone and those that are in this new protocol. Then they got the idea of the study, and they established. So that's why even the size in the number of participants is related to what was happening before and what has happened after. Yeah, and then for the second part, I think we said something like that in our view on the study, to say that it could be anything could have happened. Like I can't find the
Yeah, we did say that in our conclusion on the study, that could possibly have affected the results, that over time surgical technique may have improved, or their IPC protocols may have changed over time. Dr. Green-Thompson?
In studies I've seen where your intervention group is 3 times as large as your control group. I want you to understand why that happened, because you've got a bit of selection bias that will be coming into the intervention group. It does give you more accuracy in the intervention group with certain outcomes, but it also reduces the accuracy of the select of your control group when it's that small. If you notice, a lot of the outcomes, only 2 that are statistically significant. The rest are not statistically significant. And the thing that also shows is your obesity, one of the biggest link factors, and they mentioned it repeatedly. But your patients are generally not obese. They have a BMI of 24.
Yes.
So I'm beginning to wonder that that's one of the big difficulties, in fact, how it's not problem that put on the side. So it's just a few things that I picked up that I was thinking. Also, they didn't explain why they only took 18 months or just 2.5 years of cefazolin only versus 5 years. So you could have taken 2 years, 2 years. I'm not sure why they took a significantly longer time. Maybe just to see the effect, but it's also not randomized. So the bias does kind of creep in. It's a weakness in the study. It's still good outcome, but I think it's just something we need to keep in mind from a statistical perspective.
Yes, that's true.
It's not necessarily a weakness. When you do a study, you go for controls and cohorts. And you can go, you've seen studies where you match 1:1, you've seen studies where you match 2:1. This was probably a 3:1 type of match. Not so, they didn't mention it that way, but it doesn't necessarily weaken the study. Of course, yes, they decide they could have, as the 2 speakers have said, gone 5 years backwards, 5 years forward. But that doesn't necessarily weaken the study. The fact that they could actually control, it's still a good study. If they just told us about 5 years and they had no controls, then that would have been significantly, but they managed to control. The numbers were very good. It's not necessarily a weakness.
They didn't really explain their time durations for each one. The only thing they said in their statistics was that in order to power the study adequately, that was the numbers that were required. So they extended the intervention duration. Dr. Frank?
What's public?
February 2025.
Okay. Right. A study being presented last year in our department with similar outcomes, but it was oral azithromycin. I think it was in an African center. It was quite a large population. And then there was this discussion about should we be adding azithromycin. I mean, maybe this together with what the study is showing with the IV azithromycin, and you're saying it's in our guidelines, maybe there is enough evidence for us to be using it.
Yeah, I think we've got a high BMI population, much higher than this. Sometimes, of course, we are now implementing the prolonged intervention between when to assess. But sometimes patients have been seen, referred from clinics. So we should be considering implementing what the guidelines are saying. Because sometimes our capacity, and plus we've got a high HIV rate, very large of our patients are immune reconstituted. So yeah, I think it's something we need to bear in mind. The part we don't know about is whether we should be doing vaginal cleansing, which was in the old days of PMTCT, we used to do vaginal cleansing. So it's not something we don't know about. Yeah.
Okay, Dr. Chiti.
Regarding just 2 quick points. One, the King Edward antibiotic protocol is in there for azithromycin in there. It's actually integrated in the protocol for us to add. It's been added for the study's outcome. I don't know how much the anesthetists are actually doing it because the controversy is between the oral and the IV, but I think what Dr. Frank's thing is saying is that the African Center showed oral has the same efficacy as IV with the initial studies of IV. So I think that then is the douching from the Cochrane review with povidone has shown, and they've done it 2010, 2015, 2017, and now 2022, I think was the latest, 2020 was the latest update. They've said it definitely should be added to the protocol because on its own it's reduced. I think that's why they added the 3. But I was interested to find out why did they add the douching on top of the antibiotic, and they just combined to make the bundle the what has been shown in the evidence, and they're also saying douching on its own has been shown to significantly reduce. It's just to us to look at cost. The other thing they said is we know it's either povidone, iodine, or chlorhexidine based will reduce. So I think it's something each hospital can look at it and look at cost. They say it's not effective, but how much we have and when we're running out of things, there's something we need to look at the moment. But I think the Zitromax and the Kivazole is definitely something that can work for our patients.
Neil has got a hand in, but cleansing the vagina is not the major issue. Sister, as she's cleaning, she takes another swab and she puts it in the vagina and she swabs it, and that's it. It's not a huge undertaking, really. So it costs you. I mean, you're already cleaning the skin. When she's done all of that, then she takes the same, not the same swab, the clean swab, and she goes in, and that's it. Neil has got a hand up.
Dr. GT, you'll tell us if you're going to make that a formal protocol. Dr. Moran?
Yes, thank you for the study. I just wanted to first comment on the methods of the study. Basically, this is a very simple study, and it's the type of study that we could easily do in our setting. So I think it's nice to see such a study published. Basically, a new protocol was introduced based on the evidence in the literature, and that evidence was mainly the big international randomized control study, which was done by Alan Tita and colleagues, who came and visited us here in the department a year or 2 ago. And that was conclusively showing that adding a second drug for prophylactic antibiotics for intrapartum Caesar was important in reducing sepsis. So following that, it's a standard that you should use 2 drugs, not 1. And in Tita's study, it was azithromycin that was added. So all they did was assess the outcomes before they changed the protocol, and then after they changed the protocol. It's not a randomized control study. It's just a before and after. We can look before and after, and I think it's of value if you choose your outcomes carefully. So yeah, I think the study is what it is, and I think it's a good study. It doesn't really tell us anything new in general, because it's already a standard of care that you should give the second antibiotic. And as people have mentioned, we can't, from the study, separate the effect of the antibiotic and the vaginal cleansing, because that was two new things they introduced. But all I wanted now to emphasize was that it's in the South African national guidelines for several years now. You have to give a second antibiotic for cesarean section, especially intrapartum cesarean section. And in this study, it was second stage, where we know there's an increased risk of sepsis anyway. So it's a concern if there are any hospitals that are not giving two drugs for cesarean section prophylaxis. The cefazolin is predominantly to prevent contamination of the surgical site from the skin organisms, whereas the second drug, azithromycin, is to prevent contamination from the vaginal organisms. So for cesarean section and hysterectomy, you need two drugs. In the national guidelines, it recommends two drugs for both of those procedures. The concern about giving antibiotics, and it may cause antibiotic resistance, even in the neonate. The main point there is that antibiotic resistance tends to occur when you keep giving a drug. And that's another point that's clear in the national protocols. You should only give one dose of prophylactic antibiotic for Caesar. You don't keep giving more of it after the Caesar. And unfortunately, there are many hospitals which keep giving further doses after delivery routinely. And that practice must stop. There should be a careful evaluation for each Caesar about whether there are any specific reasons why the patient may need to have ongoing antibiotics or therapeutic antibiotics because of suspicion of sepsis. But in general, it should be just one dose, but it should be two drugs, at least for the intrapartum, because the Tita study, it was only on intrapartum. Our national guidelines, for some reason, they just do it as a general for all Caesars, but I'm not sure that's actually evidence-based. It's really the intrapartum cases. So I think those are my comments. Please make sure when you go back to your hospitals that you are following the guidelines of using two drugs. Cefazolin in appropriate weight-based doses, and azithromycin as the second drug, or if not available, metronidazole. And then it should only be for one dose, unless there's some specific reason why you need to continue it. Thank you.
Yeah, talking about that study that Dr. Moran mentioned, the one by Tita, that study was published in 2016. And since then, there have been many studies looking at validating those results. And the results have actually been mixed. Some have shown a benefit and others have not shown a benefit. So I think that's where the place of this article, the study, comes in. And World Health Organization 2021 actually recommends one dose of antibiotic. A single antibiotic, keep it simple and easy to administer. So yeah, I think the study does have some merit. Dr. Green-Thompson?
One last point from our side is, for those working in public sector, please follow the guidelines. I'm saying from a personal side, it says 2 antibiotics, give 2 antibiotics at the moment to reduce infection. And if the evidence changes, we change. But while we understand the academic discussion and for your personal practice and stuff we can do, but for public sector, please stick by the national guidelines. Thanks.
Thank you. Any other comments or questions? All right, we'll close the meeting. Have a good day.
have a question.